Hello everybody and welcome to today's webinar about one of the more common vestibular disorders, vestibular neuritis. My name is Anders Lund and I'm a marketing manager here at Otometrics, and I will be the moderator of today's session. Before we get started with the presentation, here's a little information about how we will run the webinar. In order to reduce the background noise, we have muted all participants. You can ask questions anytime during the session using the question box in your webinar menu. All questions will be collected during the session and we will answer these at the end of the session. In case we don't have time to answer all questions, you will receive an email reply after the webinar. If you experience technical problems or need immediate support, please write a message directly to the moderator who is listed as Anders Lund in your menu bar. Today's presenters are Cameron Berin from the Ohio State University, where he's an assistant professor emeritus, and we have Wendy Cromley, who's the product manager of our balance portfolio here at Otometrics. Cameron will start today's presentation.
Good morning, everybody. Anders, are we okay? Is my screen showing? Is my sound okay? If not, people, please just send a message.
It's okay.
Okay. All right, good. As Anders mentioned, we're going to talk about vestibular neuritis, which is one of the more common vestibular disorders. Those of you who were with us before, we talked about the treatment and the diagnosis of BPPV, which is the most common type. Vestibular neuritis, along with Meniere's disease, is the second most common type of vestibular disorder. The incidence in the general population is about 3.5 cases per 100,000, and it constitutes about 5% of all dizziness and 15% of vertigo cases. In some cases, you will run into this in epidemics. So you see in the emergency rooms several people coming with dizziness, and that usually follows a cold or flu outbreak for a few weeks. This can affect the patients of all ages, but the typical onset is about 30 to 60 years old, with the mean age of 41 as being the most common age, or the mean age. In most of the cases, the condition either completely or near completely recovers, but the timing can be different. In some cases, it will take only a week or a few weeks, and in some cases, it could take up to a year or more. Only 15% may have symptoms after about 1 year or so. One thing that distinguishes vestibular neuritis from Meniere's disease is the very low recurrence rate. In the studies that have been done, only out of 100 cases, only 2 cases had recurrence, and 1 was on the same side as the previous neuritis, and the other one was on the opposite side. So this will be a main feature or that distinguishes it from Meniere's disease, which has, as you know, is a much higher recurrence rate. On the other hand, vestibular neuritis, many patients, as we will discuss, the patients with superior type vestibular neuritis are at risk for secondary BPPV, and that usually affects the posterior canal. The vestibular neuritis follows what's called rules of 3. You get a sudden onset, protracted episode of vertigo, usually accompanied by nausea and vomiting. For the first 3 days, the patient has very severe symptoms. For the following 3 weeks, the patient has moderate symptoms, and then after that, for 3 months, mild symptoms. Of course, this is different from one person to another, so these are all averages. The main distinguishing factor for vestibular neuritis from labyrinthitis is that vestibular neuritis does not involve hearing loss. the most likely cause of vestibular neuritis is a viral infection, and the most likely culprit is herpes simplex type 1 virus and other herpes family viruses. In some cases, not very common, but in some cases, the symptoms might be indistinguishable from events like ischemic events that involve vestibular arteries. For example, strokes that involve pica or anterior vestibular artery syndrome. But as you will see in today's discussion, actually new test methods such as head and pulse testing and VEMPs could help us distinguish the vascular causes of dizziness from actual vestibular nerve causes. So you'll see that hopefully today. Now, we, like BPPV before that, we thought there was one type of vestibular neuritis. Now we know that there's actually, there are different types. For example, the vestibular neuritis can be caused by degeneration of the vestibular nerve. If that happens, you usually get a permanent loss. So for example, if you're doing caloric testing never recovers. And as you'll see in the case of head impulse testing, it never recovers. But most cases of vestibular neuritis now, we know that it's not caused by degeneration, but inflammation of the vestibular nerve. In fact, sometimes you can see this in an MRI. If the cause is inflammation of the vestibular nerve, once the inflammation subsides, the patient gets full or near full recovery. And by that, I don't mean compensation. It's just the function returns. And in cases of caloric testing, the caloric test becomes normal. Head and pulse testing becomes normal after inflammation goes away. Also, that the vestibular neuritis can affect different branches of the vestibular nerve. As you know, the superior branch of the vestibular nerve receives information from the lateral canal, anterior canal, and from utricle. So if this vestibular nerve, if this branch of vestibular nerve is affected, then you'll get patients who have intact posterior canal pathway, so that's why these patients are susceptible to getting secondary BPPV. A much rarer form is the type where your inferior branch of the vestibular nerve is involved. The inferior branch includes the posterior canal and the inferior portion of the vestibular nerve, saccule. So these patients are actually not likely to get BPPV because the branch that carries information from the posterior canal is actually the one that's intact. The second more common type of vestibular neuritis is the one that involve both branches. And these patients, other than the hearing loss, they have very similar symptoms to the patients who have labyrinthitis. In cases where you have vestibular neuritis that involves superior branch only, when you do VNG testing, immediately after the onset of the lesion, which sometimes we do not see unless the patient comes to an emergency room, these patients will have a very typical nystagmus. The nystagmus will be torsional, which beats away from the side of the lesion. It would be upbeating and vertical nystagmus, and it would be also horizontal, which also beats away from the side of the lesion. This is an example of an acute vestibular neuritis. You see that the right gaze, the patient has very mild left beating nystagmus. In center gaze, it becomes more pronounced, and you see a little bit of the upbeat nystagmus. These are all with fixation. And you see prominent Alexander's type vestibular nystagmus where you have left beating nystagmus in left gaze. When the fixation is removed, obviously this nystagmus becomes quite noticeable. You see very large left beating nystagmus horizontal and upbeating nystagmus for vertical. What you do not see here is the torsional nystagmus. I will play this video for you. You see the patient has torsional nystagmus that beats toward the left ear, and you will see that when the patient looks to the center, it becomes even more prominent. And right there, you can see that. And when the patient looks to the left, you will also see that the horizontal nystagmus becomes prominent, and the torsional nystagmus is pretty much the same. When you remove the fixation, now the upbeat and the horizontal nystagmus is much more noticeable, but the torsional nystagmus is still the same. It's still present. You just have to pay attention to this. Within a day or two, vertical and torsional nystagmus will decrease to the point that it may not be detectable. So this type of finding is usually seen only in lesions that are maybe less than 3 days old. So most of us do not see this in our clinic, but you probably have to go to the emergency room to see this. As a result, this type of nystagmus becomes indistinguishable from the type of neuritis that involves both branches. Horizontal nystagmus has a much slower time course and may never completely disappear if the patient has, so you might get a residual 2 or 3 degrees of nystagmus even after the patient symptom-wise have recovered. So in addition to the spontaneous nystagmus test, the caloric test will show a unilateral weakness on the side of the neuritis. This is related to the loss of nerve fibers through the superior branch, but the loss has to be significant before the caloric testing actually shows the abnormality. If only 20% of the nerve fibers are damaged, you may not get to a level that caloric weakness on the test. The caloric test can tell us whether this lesion is permanent or long-standing or whether it recovers. So it can distinguish the type that's caused by inflammation versus type that's caused by degeneration. So in those cases, in the case of inflammation, the caloric weakness will disappear after the recovery. And as, sorry. Okay, if the lesion involves just the inferior branch of the vestibular nerve, the patient will exhibit torsional nystagmus that beats away from the site of lesion and downbeating nystagmus. That is the distinguishing factor. But as I said, most of this nystagmus will disappear very quickly, and you may not be able to see it in the clinic. Caloric testing will be normal, and for that reason, this type of vestibular neuritis is not detected by traditional vestibular tests, and that's why we know very little about it. And it's only recently that we have learned that such a vestibular neuritis actually exists. Now here's a typical finding. As I promised, vestibular neuritis can be now much more fully evaluated given the video head impulse testing and vestibular evoked myogenic potentials. And my colleague Wendy is going to go show you several cases of this, so I will just limit my presentation to a couple of points here before she presents more cases. When you do video head impulse testing, the main diagnostic criteria should be the presence of catch-up saccades. As you notice here, this patient has significant catch-up saccades. These are the ones. Initially, some covert saccades followed by overt saccades. For right lateral testing, but also for the right inferior canal. So these are the branches, these are the two canals that are served by the superior portion of the vestibular branch, and you can see that the right posterior canal seems to be intact. We don't see much of a catch-up saccade here. And this finding is also confirmed by the VOR gains. So this will be a type of vestibular neuritis, the more common type, where it only involves the superior branch of the vestibular nerve. In the case of inferior branch, you will only see the catch-up saccades in the right posterior if it's a right-sided lesion, and you will not see it for the right lateral and right anterior. And in the case of both branches, all three canals will show catch-up saccades. In the case of patients who have degeneration of vestibular nerve, these catch-up saccades will be present indefinitely. The only thing that might happen is that their presence from an overt saccade might convert to covert saccade. So those of you who might sign up with us for the next October talk on vestibular compensation, we're going to talk about this conversion much more in that talk. So, VEMP findings. As you know, we can do both ocular VEMPs and cervical VEMPs. Utricle is this site that's typically associated with OVEMPs, although there's some controversy because of the few branches of the nerve that come from the saccule to the superior branch. But most people agree that the abnormal findings in OVEMP originates from the utricle and obviously from the superior vestibular nerve. This is a crossed response, so if you have a right-sided or left-sided lesion, you will record this from the right eye, and you will see a response depending on how you put your electrode. N1 occurs first, P1 occurs second. So this is the branch for the OVEMPs. On the other hand, the CVEMPs are primarily, and there's not much controversy here, associated with the saccular response and the inferior portion of the vestibular nerve, and it's an ipsilateral response, so you record that from the left-sided sternocleidomastoid muscle. And in this case, the P1 occurs first and N1 occurs second. In the case of OVEMPs and CVEMPs, we look for reduced or absent responses. In the case of CVEMPs, it's ipsilateral to the side of lesion. In this case of OVEMPs would be contralateral to the side according from the eye. If the patient has superior branch abnormality, CVEMPs should be normal because that branch is intact, and then OVEMPs should be abnormal. If it's an inferior branch only, you will see CVEMPs being abnormal and OVEMPs should be pretty much normal. If both branches are involved, both of these will be abnormal. If the function returns to the vestibular nerve, these both become symmetrical after the function has been restored. Now here's a table that sizes VHIT and VEMP responses in different types of neuritis. If you have superior vestibular nerve only, you see abnormal impulses toward the side of lesion on the lateral test, abnormal for downward impulses with the head turned away from the side of lesion, and CVEMPs would be normal, OVEMPs would be abnormal when you record from the eye muscle away from the side of lesion. If it's inferior vestibular nerve only, then you get lateral hits that's normal. Vertical VHIT will be abnormal for upward head impulses when the head is turned toward the side of lesion. CVEMPs would be abnormal for the ipsilateral neck muscle recording, and OVEMPs would be normal. In the case of total loss, you'll see abnormal lateral VHIT, you'll see abnormal downward impulses when the head is turned away from the side of the lesion, and abnormal VHIT for upward impulses when the head is turned toward the side of lesion. CVEMP would be abnormal for ipsilateral neck muscle, and OVEMP would be abnormal for contralateral eye muscle. Now the question that is a fair question to ask. Does it matter to know which type of vestibular neuritis? I know some of the ENTs in the audience say, well, what difference does it make in the treatment of these patients? At this time, I would say that the treatment option is not really changing, but just like BPPV, in the old days we thought there was only one type of BPPV and we treated it one way. Now that we know there are different types of BPPV, we can tailor make our treatments more efficient for each type. So over time, my expectation is that, for example, physical therapy and vestibular exercises will be more tailor-made for different types of vestibular neuritis. So just like anything else, once we know it exists, we can try to address that in a more efficient way. Now, what if you get a case, which I haven't discussed here? What if you get a case where the V-hit, both lateral and vertical hit, are abnormal, but C-VEMP and O-VEMPs are both normal? This is an unusual finding because it means that the abnormality is in the canal, not the utricle and saccule. Now, this actually might be the case where there is a vascular involvement. This is a very nice drawing from Kim and Lee's 2009 article, which shows the arteries that supply the vestibular nerve. I'm sorry, the vestibular organ. And you can see the anterior vestibular artery supplies blood to the anterior canal and the lateral canal, a little bit to the saccule and utricle, but utricle and saccule, they have a backup blood supply. Whereas the other, the two canals, lateral and anterior, they do not have a backup blood supply. So if you have an interruption in the anterior vestibular artery, this patient will have exactly what you saw before, where you have damage to the canals, but the utricle and saccule might be preserved. So in cases of stroke, we can usually do an MRI and find out, but this actually can become misdiagnosed as a vestibular neuritis if you have some sort of ischemic event. Usually TIAs resolve themselves within a day or so, but 30 minutes of interruption to the blood supply could cause permanent damage, and that's what you might see. So again, as you see, VHIT and VEMP combined may actually show us vascular causes, which in the past was diagnosed as vestibular neuritis, but they really are not vestibular neuritis. I will hand over the presentation to Wendy now, but I just want to finish that thought. And if you read in the literature from 1970s, it's a description of anterior vestibular artery syndrome, where this has been documented in few cases, so it does exist clinically. And the key to this is that if you identify this as a TIA, obviously the patient is at risk for stroke, and you can manage the patient more effectively instead of treating them for vestibular neuritis. Thank you again, and I will hand the presentation to Wendy.
Okay, so can everybody see my screen and hear me? I assume so. So now what we're going to talk about a little bit is the equipment side, the ICS Impulse and the Charter EP200. And I just also want to say it's very exciting to see so many people all over the world joining us today, and also my colleagues out in the field coming in to learn about vestibular neuritis as well, so they can better help our customers. So that's great. So ICS Impulse, the first thing we're going to talk about is the ocular motor module. So this assists you in the assessment of vestibular neuritis, and then it allows you to assess both spontaneous and gaze nystagmus. And as you saw from Dr. Breen's presentation, looking at the gaze nystagmus is important to determine whether the disorder is a vestibular neuritis or something else, as well as spontaneous. With the ocular motor module, you can perform the test with vision or vision denied, which you also saw that Dr. Breen showed how the nystagmus will change whether you're doing center gaze with vision or vision denied. And then the other thing is that this module does have a superior SPV algorithm to detect even weak nystagmus. And actually, Dr. Breen is the one who wrote the algorithm in the ICS Impulse, and it does a fantastic job at looking at even weak nystagmus, not just nystagmus that's greater than, let's say, 6 degrees per second, 10 degrees per second. So it does a very good job identifying nystagmus. And that is in the ocular motor module, which is an option on the Impulse that are the USB goggle. So the other module, another module is the video head impulse test. Again, as Dr. Breen showed you, this allows you to assess all 6 semicircular canals. So anterior, lateral, and posterior on the left side, anterior, lateral, and posterior on the right side, which obviously tells us, is this a superior vestibular neuritis, inferior vestibular neuritis, or does it affect both? So that's extremely helpful. We also, in the 3.0 software, we launched age-based normative gain data as well. So I want to show you a couple of cases. Actually, before I do that, just something to talk about. And I thought I'd just throw this in, but looking at VHIT versus caloric. And we're not saying that throw your caloric out, but VHIT does have several advantages over caloric. Again, you can assess the anterior and posterior canal. If the person comes in with a middle ear disorder as well, you can easily do VHIT, whereas with caloric, your 2 ears need to be the same to be able to compare for unilateral weakness. Obviously, with older patients, sometimes VHIT's easier than doing a caloric on them. And the other thing is that the person comes in, they have vestibular neuritis, but then you want to follow up with them and do a second test to see if that has recovered. Typically, more people are going to be willing to let you do a VHIT on them multiple times than a caloric on them multiple times. So that's a nice thing. So let's look at some cases, actually a left-sided superior neuritis. And what you see here on the middle column, the left lateral, you see those beautiful catch-up saccades. Left anterior, we've got the beautiful catch-up saccades, so these are these spikes in the red. And left posterior is within normal limits. And even if we look at the gain over here, is the left side. So it's in the gray area, which is abnormal for both the lateral and for the anterior. And then the right side is completely normal. So that's very typical of a left-sided superior neuritis. You can also look at this in the hex plot. So again, it shows you what's in red is abnormal, green is normal. So it's pointing to the left anterior, left lateral as being abnormal. And then the other way to look at this is in the 3D display. And one thing that Dr. Hamagi always says is look for the canyon. So you look for this gap between the head and the eye. And the blue here is the head and the green is the eye. And you can see there's kind of a tunnel in between the two of them. Versus in the normal results, the eye and the head lay completely on top of each other. So not only do you see this tunnel in the left anterior and left lateral, you also see all those catch-up saccades. So that's superior neuritis. This is a right-sided inferior neuritis. So if we look over here on this last column, right lateral is normal. Right posterior, we've got catch-up saccades. Right anterior is normal. So again, if we look over here at the gain, the red for the right is in the gray area. But everything else, if we look at all the other gains for left and right, they're all within the white, which is the normal area. So this is indicative of just a right-sided inferior neuritis. You see this on the hex plot as well, pointing to the right posterior. And then on the 3D, you see that tunnel. It's a little bit less prominent in this patient than it was on the previous patient. But you can see here you've got the tunnel and you've got the catch-up saccades. And then the last one is a full unilateral loss. So this has vestibular neuritis, both in the superior and inferior branch. And so this is on the left side. See these beautiful catch-up saccades, left lateral, left anterior, left posterior. The gain is low, the blue dots and the X is the mean. You can see that's all in the gray, and the right side is completely normal. And then when we go back to the hex plot, you see that, again, in the red, left anterior, left lateral, left posterior, abnormal. The right side is completely normal. And then in the 3D, especially in the left anterior, you can really see this nice tunnel here. It's a little bit harder to see the way I rotated it in left lateral. And you kind of see it in left posterior, but the left side is completely abnormal, and you see those catch-up saccades, right side is normal. So it's very easy with head impulse to look at the results from the 6 canals, determine is this a left side, a right side, and which canals are affected. Talking about the Charter EP200 with VEMP, the really nice thing about the Charter EP200 is that we have this VEMP monitor. So you utilize this when you're doing your cervical VEMPs. And what we know about cervical VEMPs is that they're affected by the contraction of the neck muscle. So if you have more contraction, you're going to get a larger amplitude. If you have less contraction, you're going to get a smaller amplitude. So in order to compare the left side and the right side, you want that contraction to be the same on both sides, because you don't want to get an artificial unilateral difference just because they didn't contract or turn their head the same degree on both sides. And so what the VEMP monitor does is it helps you make sure that that contraction is the same. And the way it works is that you have the person turn their head, so you get an average range for them, which is usually, I believe it's like 60 to 100. But you get the average range, and then you put in the software, you put what your minimum and maximum range is going to be. And then when they're within that minimum maximum in the contraction, the green light comes on, which you see here in the picture. That's good. So you know they're holding a contraction in the range that you want them to, and that minimum maximum number is the same for both the left side and the right side. If they contract too much, the orange light, which is the high, says high, would come on. If they're not contracting enough, a blue light for low would come on. So it makes it very, very easy to monitor the contraction of the neck muscle. It also has a asymmetry ratio. We provide this normalized and not normalized. And the other thing is we also offer a cable and instructions for people who want to do bone conduction VEMPs. And typically most people want something with a little more oomph than a B71 or B70 would give you. So a lot of people use the B&K amplifier or mini shaker. Most people at least use the mini shaker, but you can use different amplifiers. But we do have a whole setup, a cable and everything, where you can set up your system to use the B&K amplifier and mini shaker. So this is actually normal results. We didn't have any examples of vestibular neuritis in for our EP system, but this is showing you the cervical VEMP. And so on the left side, you've got left ipsilateral. This is done at 90 dB. So you can see the P1 and N1 are marked. Now in some countries like Australia, they flip this around so that your P1 is going down and your N1 is going up. And really that's just the way that happens, is just which way you put your electrodes on, which is your positive, which is your negative. Either way is fine. And then on the right side here, we see it's right ipsilateral 90 dB in the P1 and the N1. And then we compare the amplitude of these two. So when you're doing the test, you actually see the EMG number up here in the box that's currently blank. And then in the list of the test info, it actually tells you what the average EMG was for each one of those traces. But again, if you're using the VEMP monitor, you know that your EMG was equivalent on both sides. So then you highlight the two, which you see number 4 and number 1 are highlighted, and it calculates for you the asymmetry ratio. And then in OVEMP, we'll notice here this left C for contralateral, 97 dB at 1,000 hertz. And so remember, as Dr. Green said, if you're collecting from the left eye, you're actually testing, it's a contralateral response, so the stimulus is going into the right side. So this is left contralateral, right contralateral, and then you can compare the two. And N1 is going down, P2 is going up. So that's for the VEMP. So again, you can do this air conduction or bone conduction. And then I'm going to hand this back over to Dr. Breen. Okay, Dr. Breen, I think.
All right, I will be showing my screen here. Okay, to just summarize what the whole presentation, vestibular neuritis is a very common cause of dizziness, but unfortunately up until now, when we did VNG or rotation testing, we didn't fully diagnose the condition. We couldn't identify the different types of it. Today, with the presence of VHIT and VEMPs, we can identify the involved branch, and hopefully very soon we'll be able to develop rehab procedures that are more targeted for different types of vestibular neuritis. I will hand back my presentation to Anders to see if there are any questions, and thank you again everybody for attending this. It's been a pleasure.
All right. Let's see. So thank you, Cameron, Barin, and Wendy. We did receive one question here, at least, and I would like to hear: can we monitor recovery with VHIT and VEMP?
Can you hear me? Am I still on?
Yes, you're on.
Okay. Wendy, do you want me to take this question? I think she's muted, so I'll go ahead and take the question.
Go ahead.
Yes, actually, you can monitor the recovery, and again, this would be a good way to distinguish this from something like Meniere's disease. In the case of recovery, what you will end up seeing two distinct type of finding in the VHIT. Initially, as the patient recovers, most of the patients will have overt saccades, which means these saccades are visible even with the naked eye. Over time, and that's fairly quick, we're not talking about weeks, it might be within a few days, you may end up with nystagmus or with catch-up saccades that convert to overt saccades. To covert saccades, and this is usually present whether it's a degeneration type or whether the inflammation type. That is just a part of the compensation to allow the patient to have clear vision, even if their vestibular system is completely damaged permanently. The second type of recovery that you might see is actually when the inflammation goes away and the function returns. In this case, all of the catch-up saccades, for the most part, will disappear. Now, just like spontaneous nystagmus, in most of these patients, you see mild catch-up saccades even after the patient is completely recovered. So there might be a slight amount of asymmetry that remains in these patients, but for the most part, the catch-up saccades disappear. So you will see this in your VHIT responses. Now, this goes to the topic of vestibular compensation and how we deal with these different types of permanent loss versus temporary loss. And again, as I said, our next webinar will involve Dr. Schubert, who will give a very good overview of these conversions between overt and covert saccades. And so I invite everybody to come back to that. I know it's going to be a very interesting talk on his part. Thank you again. If there are any other questions, if you send them by email or just type in.
Yeah, I
Wendy
think
and I will be happy to answer.
Yeah, we've got one more here that I think we can answer. It says, sometimes I find what looks like significant catch-up saccades, but the gain is higher than 0.1. Does it mean anything? And I'll start, Cameron, then you can add on. You've got to rule out anything like user error. So make sure that the goggles are on tight. Make sure that the face cushion is on, and sometimes a newer face cushion is better than one that's been used several times. You want to make sure that the patient is at least a meter away from the fixation dot. If they're too close, you'll get convergence, which will cause a higher gain. So you want to rule out all that information, and we can actually, Anders, we can send you a handout that will kind of outline everything. Then, if you've ruled out everything that could possibly cause any kind of goggle slippage, or anything that would cause a higher gain, like the proximity of the patient to the fixation dot, there are some, I think, rare cases where once the person's somewhat compensated, you can still have catch-up saccades and the gain be in the normal area. Cameron, do you want to comment on that?
Yeah, I think I agree with exactly what Wendy said. Most of the cases, when I look at VHIT, my first criteria for interpreting the test is the presence of catch-up saccades. And by presence of catch-up saccades, I mean significant catch-up saccades. They have to fit a criteria to be considered significant catch-up saccades. Because even if you have at the very high velocity, even normal people may have some residual catch-up saccades. Generally, these catch-up saccades would be much smaller than the head impulse, the peak velocity of the head impulse. So, for example, if I'm testing the patient at 250 degrees per second and I get a catch-up saccades that's 50 degrees per second, I will just simply ignore that, because that means that even in a normal individual, if you turn the head quickly enough, you get to the asymmetrical range. So that small catch-up saccade is the demonstration of the actual asymmetry that exists in high velocities, because the responses from the canals are saturate when you move away toward the one side versus the other side. Saccades are large enough. As Wendy said, that may be residual catch-up saccades. It might be that the gain, as Wendy suggested, might be contaminated by some other factor. So I always look at the catch-up saccades, and if I see them, then I look at the gain, and then based on how significant the catch-up saccades are, then determine if that gain really matches that or if it doesn't match that. If you have, for example, a significant asymmetry between the gains, even when it's both in the normal range and you have catch-up saccades, that probably indicates some asymmetry, and if the patient is symptomatic, obviously that might be the cause of the symptoms. So basically you interpret that the gain based on what you see on your catch-up saccades and how significant those catch-up saccades are, and consistency is a big factor. If you have only 2 or 3 catch-up saccades in the 20 or head impulses that you're doing, that's probably not significant.
Okay, just a couple more questions I think I can answer quickly. Eric, I'll make sure that I have the Italian team get in contact with you and someone can come see you out in Rome. Tatiana, regarding overshoot and wrong plane stimulated. Overshoot is actually when you're moving in the direction you want to test, and then you're bringing the head in the opposite direction too quickly. So when you do a head impulse, you want to make sure, if I'm doing a leftward lateral, I do the head impulse to the left, but I do a stop, an abrupt stop, and I'm not moving back rightward too quickly. And the reason why that's important is you don't want to be stimulating the left side and then the right side, because then you don't know where your response is coming from. And regarding wrong plane stimulated for LARP and RALP, that means that either you don't have the head turned enough, or you're pitching the head towards the nose instead of towards the canal. And we'll make sure, if you go on ICSimpulse.com, click on how it works, and then scroll down and go to the LARP and route video. That information I think you'll find very, very useful. And then, I'll email you because it also depends on what version of software you're using. If you're using 2.0 or 3.0, we have the head position feedback in there, which gives you a lot more indication that it helps you position that head properly, and makes it a little bit easier to do LARPs and RAPs. The next question, Cameron, I believe is for you, from Monica. In the case of anterior canal abnormal result in VHIT only, and she said it's unilateral, what does it mean, and should we suspect central causes?
Well, I think it will be difficult to identify central causes from VHIT. VHIT is a very specific test for canals. So in the case when you have only anterior canal abnormality, I will look for two things. One is that you may have a milder loss on the lateral canal that you're not detecting. So if you have some catch-up saccades, but it's not that significant, that probably is similar to superior vestibular nerve abnormality. But on the other hand, if you have a completely normal lateral and posterior canal findings, and this is only confined to anterior canal, it would be very unusual, but there's no rule that says you cannot have a singular canal abnormality. What it means is that the nerve is intact. There's no damage to the nerve, because then you would expect to have lateral canal involved too. So this is an isolated, that would be considered an isolated anterior canal abnormality. Again, physiologically or pathophysiologically, it would be hard to explain why you would have only one canal, but it is possible. So I would not necessarily think that that's a central cause.
And then, Cameron, one other question. During the VHIT, what if vertigo is triggered? Does it show on the VHIT?
Generally, if you're doing the test correctly with VHIT, you should not be generating any vertigo. I have seen this happen in cases where the examiner is inexperienced and they're doing multiple, let's say like 400 rejections and things like that when they're doing the testing. In some cases, patients who have BPPV, you might be in the especially RALP and LARP triggering some BPPV cases. Generally, the rule is small amplitude head movements. This could only happen usually if you have doing very large head movements. That's not really the way the VHIT should be done. Again, the videos that Wendy mentioned will give you the correct way of doing this. And the other thing is that if you get to the rejection of like 50, 60, stop, don't continue, because that means you're doing something wrong, or something, maybe the pupil is not being detected correctly, or you have some artifacts, maybe you're not turning the head correctly. If you get 50, 60 rejections, don't continue doing the test, because that's when you might trigger the bout of vertigo. In the cases I have tested, that has never occurred. So it's mostly when you're not doing the things correctly. And maybe Wendy would want to add something to that as well.
No, the main thing is, like Karen mentioned, the videos on icsimpulse.com. They're very helpful. So I would look there. But I will email you to make sure that you get whatever you need to make sure that you are properly doing the head and pulse test. So, and then I think, Anders, this one's to you from Paula. Is there a way for them to get the presentation on the web or by mail? Just because when English isn't their first language, sometimes having the presentation to look over it again would be helpful.
Sure. I mean, we will do a recorded version of this webinar that we will send out to everybody, and we can also send the presentation in case you find it useful. So
I think, Anders, in the past we have, with the link to the video, we have also included a handout. I'll be happy to send you a handout if you want to put a link to that.
Okay, let's do it like that.
So I think those are, Anders, you were able to see some questions that I wasn't able to see, so I covered everything that I can see.
You have
Did we miss
covered
anything
everything.
that you see on your screen?
We've covered everything. So,
Okay.
and I think it's time to wrap up. We are running a little bit late here, so but thank you for staying on, everybody, and we're looking forward to the next one, October 20th, where we hope you will join back for another webinar. All right, thank you.
Thank you.
Thank you.